Rosa and Professor Rayner. It's a pleasure for me to be here. My thanks also to the organizing committee. It's my third or fourth trip to Brazil, and I really enjoy coming, but my first time to Campinas, and the hospitality has been wonderful, so my gratitude. A couple of weeks ago, maybe a little bit more, Derek sent me a message asking me if I would change the topic of my seminar today. And I said, okay, what topic did you have in mind? And this was the title that he gave me. And for a minute, I scratched my head and said, I don't work in this area, and I'm wondering if he's confusing me with Bernie Zinman or Subodh Verma. We're all in Toronto, but we're at different centers entirely. And then I sat back, and he reassured me. He said, no, just do a review, and you're familiar with this class of medications, and indeed I am. In fact, not a single cardiology clinic will go by where I'm not writing a prescription for one of these agents. So it was on that basis that I agreed, and what I thought I would do is really provide where we are of our knowledge of this class of agents, and perhaps a little bit about where I think we may be going. Here are my disclosures. So I've divided the next 25, 30 minutes into sort of 5 sections. The first is really taking from the title that Derek gave me, which is, what is modern drug therapy for type 2 diabetes? What do we mean by modern drug therapy? And in a nutshell, I think it's moving far beyond glucose. And I think you've heard a little bit of that this morning from Professor Pfeffer. I'll talk about SGLT2, the sodium glucose cotransporter, and why it is a relevant therapeutic target in type 2 diabetes, just from the pharmacology and physiology perspective. Then I'll review, as succinctly as I can, the glycemic, metabolic, and hemodynamic effects of agents that inhibit the transporter. And then I'll review, I think what probably everybody in this audience is already familiar with, is the aggregate of data on the cardiorenal safety, benefits, and I'll just touch briefly on what we believe may be the mechanisms of action underlying those cardiorenal benefits. And as I mentioned, I'll then try to project what I think the future may hold. So let's start with, what is modern drug therapy for type 2 diabetes? And I believe it has nothing to do with blood sugar. Now, I don't mean to offend my diabetology colleagues. It's very important to control blood sugar. Patients feel better. We have great epidemiological data that you prevent the progression of retinopathy, nephropathy, neuropathy with excellent glycemic control. But until the trials you've heard about earlier today were around, there was precious little evidence that maintaining good glycemic control did anything for cardiovascular outcomes. So I think that the way to think about this is to always keep in mind that type 2 diabetes almost never occurs in isolation. This entity really occurs in an environment where the majority of the patients are overweight or obese, and as you'll see from the cardiovascular outcome trials, the mean body mass index is 32 in almost all of those trials. They're obese patients. I have yet to meet an individual with type 2 diabetes who doesn't have a dyslipidemia, whether it's from the triglycerides, the low HDL, or they're at least borderline elevated LDLs. And about 80% of individuals with type 2 diabetes have poorly controlled blood pressure and require agents for the treatment of hypertension. And again, in all of the cardiovascular outcome trials, if you look at the prevalence of antihypertensive agents, it's 80 to 90% in these studies. So we're really talking about a disease entity that has a lot of comorbidities, and focusing on the treatment of diabetes is simply insufficient in the modern era. And these 3 central risk factors for coronary artery disease accelerate atherosclerosis. Diabetes is a uniquely toxic environment in which you get not only epicardial atherosclerosis, but we know you get small vessel disease. And indeed, some individuals end up with this poorly understood entity of diabetic cardiomyopathy, which we still believe is microvascular ischemia. And when you put diabetes and hypertension together, Again, these are the two leading risk factors that lead to nephropathy. And as nephropathy progresses, our arteries become more brittle and calcified, and this even greatly accelerates now the clinical manifestation of underlying atherosclerosis with plaque rupture and acute thrombotic events leading to the clinical presentation. And of course, when you put hypertension, kidney disease, and coronary artery disease together, how are you not going to be at risk of developing heart failure? I don't have time today to go into this, but completely independent from these comorbidities and conditions, there is an unequivocally direct relationship between type 2 diabetes and the risk of developing heart failure, both preserved and reduced ejection fraction heart failure. So what's the magnitude of this thing that I've mentioned, these three conditions that I've mentioned? So Professor Pfeffer mentioned the Framing on Heart study. This study from a few years ago in Circulation looked at about 3,500 men and 4,500 women, took them at age 50 and made sure that they had no manifestations of coronary artery disease and essentially projected forward their lifetime risk of developing coronary artery disease. And in men, age 50 without cardiovascular disease, the lifetime risk is 52%, and in women, it's just under 40%. But if you now segregate them into those with diabetes and those without diabetes, you can see that the risk that diabetes entails is very powerful, with men having a 67% risk and women having a 57% risk of developing coronary artery disease. So the treatment of diabetes, neglecting the prevention of progression of coronary artery disease, would not be modern therapy. Diabetes is also the leading cause of progressive kidney disease, end-stage kidney disease, the number one reason a person will end up on dialysis or transplanted. And this is not just an epidemiological problem. This has real life morbidity and mortality issues. In this data set, what the investigators did was take a reference population and then compared them to those individuals with either early chronic kidney disease, diabetes alone without chronic kidney disease, or early diabetic kidney disease. And as you can see, there's a progressive decline in the expected lifespan, with the prediction being you lose about 16 years of life, even with very early evidence of diabetic nephropathy. And this is only going to get worse with the prevalence of both diabetes and hypertension, the projected both global and regional, and in Asia, North America, South America, we're expected to have double the number of people requiring renal replacement therapy over the next 10 to 11 years. So this is a real emerging problem, and anything that can be done to forestall this, to delay or defer this, is a worthy goal. And finally, I think heart failure, this audience is probably very familiar with the fact that not only does it occur more often in individuals with type 2 diabetes, but when the two occur together, there's a particularly poor prognosis. There are many such data sets. I've sampled this one, which is about 5,500 patients, cohorts in Asia, Singapore, Malaysia, Hong Kong, China. And as the graphs will show you, if you have diabetes and heart failure, in this instance it was reduced ejection fraction heart failure, the prognosis is quite grim, with a 25% mortality at 1 year, and very similar data anywhere in the world. And what we've learned is that the treatment of diabetes before the emergence of the SGLT2 inhibitor class and the GLP-1 receptor class had a great deal of difficulty demonstrating benefit. So my colleague Jay Udell at the University of Toronto published this, I think, very useful meta-analysis. It's a few years old now and doesn't include the two drug classes that we're all now so excited about. He looked at 95,000 patients with a median follow-up of about 4.5 years, in which there were 4,000 heart failure events. And what these studies, which were all designed to test improvements in glycemic control, demonstrated was about an overall very modest 5% reduction in MACE, 8% reduction in non-fatal myocardial infarction, and what had been emerging at that time was this recognition that there was actually an increase in the incidence of hospitalizations for heart failure. That was 14% as a relative risk, 0.5% as an absolute risk. And when they looked a little bit deeper, it was driven by TZDs. In fact, this is what started the ball rolling on the FDA and the regulatory requirements for new diabetes drugs. To some extent, the DPP-4 inhibitors, and to a smaller extent, even insulin. They made a summary statement that glucose-lowering agents by various strategies may increase the risk of heart failure, the size of that risk depending on the method by which you reduce blood sugar, and potentially weight gain. And I won't go into it, but they plotted out weight gain with risk of heart failure and calculated about a 7% relative increase in heart failure for every 1 kilogram of weight gained during the course of these studies. So that's the backdrop. Let me turn now to SGLT2 as a therapeutic target in type 2 diabetes. So here are data of human tissues looking at sodium glucose cotransporter 2 expression. And you'll appreciate that the most abundant expression is here in the kidney, and therefore any drug designed to inhibit this would have very little off-target effect. There's a little bit in the brain, a little bit in the testes, but these studies are very prone to error. This study was looking at RNA, not particularly at protein, and I'll come back to that in a moment. And if you look at the cousin of SGLT2, which is SGLT1, you'll appreciate immediately that it's the gut and the heart which emerge as quite abundant presence of this transporter, and skeletal muscle. And you'll appreciate that the kidney hardly appears on this study. And yet we know that the kidney has quite a bit of functional SGLT1. In fact, is responsible for about 10% of glucose reuptake in the kidney. Now, how do you develop a drug? Well, this is a great example. It's originally isolated in the early 1800s, almost 200 years ago, from the bark of the apple tree, the compound florazin, which was recognized as having this ability to reduce blood sugar. And all of our current SGLT2 inhibitors are structurally similar to this small molecule. Here are the three that I'm sure all of you are fairly familiar with: canagliflozin, dapagliflozin, and empagliflozin, all once daily administered, all peaking very early with high oral bioavailability. They're all removed by glucuronidation, and they have no active metabolite. Here's their elimination half-lives. You'll see that it's hepatic and renal dominant, with the exception of empagliflozin, which is about equivalent between hepatic and renal. And here's the selectivity over SGLT1. So this is the preference of the molecule to inhibit SGLT2, and you'll see that it ranges from 1 to 160, which is still therapeutically more than selective, out to the most highly selective of 1 to 5,000 with empagliflozin. And the half-life of each of these makes it quite suitable for once daily administration. So I think you're all fairly familiar with how these agents work. Once the SGLT2 inhibitor is in place, any glucose that is filtered through the glomerulus is no longer reabsorbed. Only small amounts are reabsorbed by SGLT1, resulting, of course, in glycosuria. The magnitude of that glycosuria is fairly significant. It corresponds to between 200 and 300 calories per day, which is the basis of the weight loss that occurs in patients treated with SGLT2 inhibitors. It's also responsible for the sodium excretion because it's a sodium glucose cotransporter. And when you put a higher osmotic load down the collecting duct, you in addition have an osmotic diuresis. The overall summary, and I'm going to go into the specifics of the data, are as follows. You get about a 0.7 to 1% decrease in A1C, a 2 to 3 kilogram weight loss, a 3 to 5 millimeter of mercury drop in systolic blood pressure, and a 2 to 8% increase in LDL, which is poorly understood. But before I get to the individual mechanisms, I just want to highlight this paper published in Nature Medicine, which is quite an elegant study which just demonstrates that any human data available can be imperfect, whereas they clearly mapped out glucagon marking the alpha cells, insulin marking the beta cells, the presence of SGLT1 and SGLT2 co-localizing in human islets. And this is not just presence, but functionally relevant. In human islets, again, demonstrating messenger expression of SGLT1, SGLT2 predominates in the alpha cells. And interestingly, in the presence of an SGLT2 inhibitor, you actually increase the low glucose mediated secretion of glucagon. And therefore, patients taking SGLT2 inhibitors will have higher glucagon levels. And this is independent of a gluconeogenic benefit, and what effect higher glucagon levels have on glucagon receptors elsewhere outside of the pancreas is of potential interest. Let me move now to summarize the glycemic, metabolic, and hemodynamic effects that underlie that basic table that I quickly showed you. So all of these next 3 slides are structured similarly. These are the phase 3 studies that were done to demonstrate glycemic efficacy. The baseline hemoglobin A1Cs in these studies are around 8 to 8.5%. This is on top of or compared to metformin, SU, pioglitazone, insulin, SU, DPP-4 inhibitors, or even GLP-1 receptor agonists. And you'll see that they're all relatively short duration studies between 4 to 6 months in length. And you'll see that at the doses of canagliflozin here, 100 and 300 milligram, there is a dose-dependent increase in the reduction in A1C. It's pretty consistent across the board, and it is dose-dependent. So you do get more blood sugar reduction if you use the higher dose of canagliflozin. Dapagliflozin, a very similar story. The phase 3 studies were in patients with hemoglobin A1Cs between 8 and 8.5%, and now you see this 0.75 to 1% reduction in hemoglobin A1Cs, dose-dependent, less of a difference between the 5 and 10 milligram doses of dapagliflozin. And finally, with empagliflozin, very similar results. You'll appreciate that these agents are pretty consistent in their efficacy in similar background patients, again, baseline hemoglobin A1Cs of 8%. And from these same data sets, where available, the aggregation of pool data with body weight, you'll appreciate 2 to 3 kilograms with canagliflozin, 1.5 to 2 kilograms with dapagliflozin, and about 2 kilograms with empagliflozin. So this is where that 2 to 3 kilogram summary comes from. And with regards to systolic blood pressure, and I'll remind you that these are phase 3 studies in most of whom patients with underlying cardiovascular disease, older patients are not included. So these tend to be the lower risk patient populations, but this is where we see the 3 to 5 millimeter mercury systolic drop in blood pressure in individuals treated with these agents. Now, what happens when there's moderate renal impairment? Because the mechanism of action, of course, requires filtration of glucose at the glomerulus, and one would imagine that you would have less efficacy in that context. So here, looking at a baseline eGFR of around 40, 44, and 43, very similar in the pooled data available, you'll appreciate that the drop in A1C is less than half that of what I showed you in the previous slides. So about 50% of the glycemic effect is lost with moderate renal impairment. Now, what about safety? So again, this is a meta-analysis of 45 studies looking at urinary tract infection versus placebo and urinary tract infection versus active comparator. The percentage of patients getting a UTI is around 7 to 8% in all of the SGLT2 data combined. This is a 30 to 40% increased risk compared to placebo or active comparator. So in communicating with your patients, this is the magnitude that you would communicate about a 30 to 40% higher risk of urinary tract infections. Genital tract infections, although somewhat less common, have a higher magnitude of relative risk, a 3 to 5-fold higher risk from balanitis to candidiasis and vaginitis. These are the common genital tract infections that occur because of the increased glucose in the urine. And what about low blood pressure, particularly in older patients on multiple antihypertensive agents? The incidence is actually quite low, about 1%, and about 50 to 150% increased risk. I'm going to come back to some other complications in a moment. The renal-related adverse effects were pretty flat here. You'll appreciate that this really did not cause, in the phase 3A studies, any concerns with diminishing renal function. Dehydration, however, may increase the likelihood of acute kidney injury, and the elderly on diuretics or other RAS inhibitors may be at higher risk group, but really this didn't pan out in the phase 3 studies. The one important counseling that we developed in Canada, and Diabetes Canada educated this rather well, was what we call sick day medications, and the acronym is SADMAN. So for patients who are unable to maintain adequate fluid intake, we generally recommend avoiding sulfonylureas, ACE inhibitors, diuretics, metformin, ARBs, nonsteroidals, and, of course, SGLT2 inhibitors. DKA, a feared complication that's actually quite rare, less than 1 in 1,000 patients treated with an SGLT2 inhibitor, and it's unclear if this is occurring at a higher frequency than before the advent of SGLT2 inhibitors in practice. The majority of these are occurring in those patients that have insulin deficiency, and some are euglycemic, so you have to be vigilant. If a sick patient comes in, they're not always overtly hyperglycemic, and most cases, however, do have a precipitation infection such as that. Let's move to cardiorenal safety and benefits. So I think that you're all quite familiar with these studies. EMPA-REG outcome, CANVAS, declared TIMI 58, and I've added credence here as not only a cardiovascular, but now a renal outcome trial. The ages, the BMIs, the proportion that are female are very consistent. The longest duration of diabetes was in credence. Where they differ was in the background of cardiovascular disease. Only 40% of the patients in DECLARE had cardiovascular disease, and only 50% in credence. And you'll appreciate the entering mean eGFR was in the 70 to 80 group, whereas credence by design is looking at the progression of nephropathy and had a mean eGFR of 56. So in the EMPA-REG outcome study, these are data you're very familiar with. I will just highlight them very quickly. A 14% reduction in the 3-point component MACE of cardiovascular death, MI, and stroke, and a 38% reduction in death by cardiovascular cause. So really it was cardiovascular death that drove the primary endpoint. MI moved in the correct direction but was not significant, and stroke moved in the wrong direction but was not statistically significant. That signal with stroke, which is not a statistically significant signal, has not been observed with the other SGLT2 inhibitor, CVOT. The big news here, and this has been mentioned several times today, was the effect on hospitalization for heart failure. It was early, it was sustained, and it was consistent across almost all patient groups looked at: the young, the old, background of heart failure, baseline kidney function, hemoglobin A1C. It didn't matter. This effect was very consistent. Canagliflozin had an identical reduction on 3-point MACE, 14%, and a 33% reduction in hospitalization for heart failure. Canagliflozin also reduced adverse renal events, 27% on the progression of albuminuria, and 40% on this composite of a 40% reduction in eGFR, requirement for renal replacement therapy, or death from renal causes. What was first observed in the CANVAS program was the increased incidence of amputations at the toe or metatarsal level. This is 6 per 1,000 patient years. It is obviously a feared complication that you have to talk to your patients about. The hazard ratio is 2.0 versus placebo. It has not been observed in credence, arguably advanced kidney patients with just as much peripheral artery disease, and was not observed in the other two SGLT2 studies. In DECLARE TIMI 58, we had a 17% reduction in death or hospitalization for heart failure, and to some people, a surprising neutrality in the other primary outcome of MACE. But I will remind you that only 40% of the patients in this study had underlying established cardiovascular disease. Dapagliflozin also reduced renal outcomes by 24%. There's been a very nice meta-analysis done, published earlier this year by Zelniker and colleagues in Lancet, which took a fairly sophisticated approach to putting all of these over 30,000 patients together. And their conclusion in this analysis that I'm showing here, which has a p-value of interaction of 0.05, is that there appears to be benefit in patients with established atherosclerotic cardiovascular disease, but not in patients with multiple risk factors. Coming back to, in whom do we see the benefit? I want to contrast this with a very nice study done by my colleague Mikhail Kosiborod, which is CVD Real. Now we're looking at real-world data, not randomized clinical trial. One can argue which is the more accurate of predicting clinical outcomes, but they identified with or without prior cardiovascular disease benefit on death, heart failure, and heart failure plus death on the aggregate of 150,000 patients treated in clinical practice with an SGLT2 inhibitor versus 150,000 propensity-matched controls. Let me end with credence. Was credence necessary, and was it important? Why was it done? So that same meta-analysis in the Lancet also looked at the worsening of renal function, end-stage kidney disease, or renal death as a function of baseline EGFR. And as you'll appreciate, there is very high benefit in people with normal EGFR and apparently diminishing benefit in patients with more advanced renal disease. And the interaction p-value here was less than 0.03, raising the notion that perhaps the prevention of nephropathy, that benefit is lost in patients with more renal dysfunction. And therein was the basis of credence, where patients were randomized. At time of enrollment, they had one would almost call macroalbuminuria, 300 to 5,000 milligrams per gram of albumin in the urine. And I want to demonstrate who these patients really were. You'll see that about a third of the patients had EGFRs between 30 and 45, a third between 45 to 60, and only a third would be in that 60 to 90 range. And you'll appreciate that 3/4 of them had quite significant albuminuria. And the benefits of credence have been shown earlier this morning: 30% reduction in the primary composite, 34% reduction in the renal-specific composite, highly statistically significant. They also demonstrated almost equivalent reductions in progression to end-stage kidney disease or the composite of dialysis, kidney transplantation, or renal death. I want to contrast those 30% reductions with the only other proven therapy to prevent diabetic nephropathy, which are dated studies, Renal and IDNT, where the risk reductions were more in the 15 to 20% category, and also remind you that credence was done on a background of ACE or ARB. The patients had to be on for 4 weeks and throughout the trial. And here are the EGFR plots. There's always a small but significant drop in the EGFR shortly after initiation of SGLT2, but it's over time where you really begin to see the protection such that the delta is about 2.7 points of EGFR per year. The mechanism, I don't have enough time to go through in detail, but it's believed that in diabetes, when there's hyperfiltration, there's an upregulation of sodium glucose transport such that diminished sodium reaches the macula densa. This is sensed as a hypoperfusion. There's a vasodilatation that leads to more hyperfiltration. And what happens with an SGLT2 inhibitor is you restore sodium delivery, you vasoconstrict that afferent arteriole, you protect the glomerulus from high pressures. With regards to the cardiac benefits, the simple answer is we don't fully understand. Most people will believe that it's this reduction in plasma volume, some combination of a cardiorenal protection axis. The metabolic hypothesis of ketones, I'm not particularly impressed by. My colleague Subodh Verma, who maybe Derek confused me with, has completed EMPA-HEART. They haven't published it yet, but they've presented it at the AHA, and they demonstrated a decrease in left ventricular mass index by magnetic resonance imaging, a quite significant reduction over a short duration of time. So there is adaptive remodeling of the heart in this study of EMPA-REG type patients in EMPA-HEART. Let me end with where the future might hold. I see this being of three sorts. The potential for benefit in non-diabetic patients with CVD, the potential for benefit in non-diabetic patients with CKD, and, has been mentioned by John in his wonderful presentation, potential synergistic actions with GLP-1. So where are we in receiving these data? So I've shown you Credence, which just published earlier this year. In a few short months, we will hear DEFINE-HF, which will be the first heart failure study that enrolled patients with reduced ejection fraction heart failure, irrespective of whether they had diabetes or not. And then later we'll hear about DAPA. This is a much larger study looking at heart outcomes. This is only a few hundred patients looking at functional outcomes and quality of life questionnaires. And then 2020 will be a big year. We'll have Emperor Preserved, Emperor Reduced, and also DAPA CKD. This is to look at the beneficial effects on the kidney independent of patients with diabetes. And then early in 2021, with a new SGLT2 we haven't heard much about yet, sotagliflozin, will have an acute heart failure study, and then DELIVER will be another study with dapagliflozin in preserved ejection fraction heart failure. I will end with this notion of combining the agents. SGLT2 inhibitors have many beneficial effects. They do increase glucagon secretion, and they reduce insulin secretion. There is more hepatic glucose output and this ketone output, and we've already talked about the benefits are more along the lines of heart failure, whereas with the GLP-1 receptor agonists, you reverse all of these effects, and you seem to have more of an effect on atherothrombotic progression. So there's really good logic in combining these two. They have already been combined in phase 3 type studies for glycemic control, demonstrating synergistic benefit, but we don't have, of course, any outcome studies. So to end, I've shared with you my belief that modern drug therapy for type 2 diabetes must address cardiovascular events, heart failure, and CKD. At a minimum, we know the drugs have to demonstrate safety, but I don't think that's sufficient. They really now need to demonstrate benefit because we now have two classes of drugs that do. SGLT2 inhibitors are effective, easy-to-use agents that reduce A1C, body weight, systolic blood pressure. They reduce MACE in patients with established CVD. They reduce CV death and heart failure in type 2 diabetes with or without established CVD. And they reduce adverse renal events in type 2 diabetes with or without CKD. Whether they will hold promise in reducing heart failure or renal outcomes in HFpEF, HFrEF, and CKD without diabetes are being studied in clinical trials that we don't yet have the results for. Thank you very much.